Uh, Good evening to all of you. My name is Chamat Ravindra. As students involved in Rational Health Activities, or SIRA, I warmly welcome you all to this meeting. Before starting the meeting, I would like to know whether our guest speakers have joined the meeting. I can see Professor Krishantha Weerasuriya, Indika, sir. Are you there, sir? Manuj, sir, are you there, sir?
Yes, I have logged in.
Indika, sir. So shall we wait for some time for Indika sir to join, or shall we proceed, sir?
You can start, no? Since many are here.
Okay, okay, sir. Okay. So we have gathered here today via the Zoom virtual platform to talk about one of the most important things a healthcare professional in Sri Lanka should be aware of and should be acting to secure. That is the drug policy of Sri Lanka. There's a special reason we specifically selected today for this webinar because today remarks the 43rd commemoration day of Professor Senaka Bibile, who was the pioneer of drug policy in Sri Lanka. Professor Bibile passed away on 29th of September 1977 in Georgetown, Guyana. So today marks the 43rd of his commemoration day. So before starting, we prepared a small video as a tribute to Professor Bibile. So we'll go to that. Uh, So if someone asks from you who was Professor Bibili and what he did, you may start. You may start. You may have a start, but at some point you may don't know how to describe. So as medical students and as healthcare professionals, we think that we should be aware of what Professor Bibili did and what it achieved and how we are going to secure that. So this discussion is about that. So without further ado, I would like to introduce today's guest speakers. We have three guest speakers today. Let's get to know our speakers. Okay. We warmly welcome you, sir, Professor Krishantha Weerasuriya, Professor Manuj Weerasinghe, and Professor Indika Karunathilake. Professor Indika and Professor Manuj is joining us from Colombo, Sri Lanka. A very good evening to you, sir.
Good evening, Chamat, and good evening to all of you.
Professor Krishantha Weerasuriya is joining us from Geneva, Switzerland. A very good afternoon to you, sir.
I can't see Professor Weerasuriya in the list.
Oh,
Because,
can you hear me now?
Yes, sir.
Yes, sir. Yes, sir.
Yes, sir.
Okay,
We can hear you,
right.
sir.
Yeah. Thank you
Good
very much,
afternoon, sir.
Chamat. Yeah. Good afternoon. And unlike the younger people, we are a little bit behind in the technology. Thank you for organizing the meeting. And yes, please go on.
Okay. So, without further ado, let's start our discussion. First of all, my first question is, so what was the drug policy during the 1950s, 1960s? That is the sort of the beginning of the healthcare system, the drug policy in Sri Lanka. So, can Manuj sir or Krishantha sir can give a description or explanation about that?
Sir, if you can start, that would be really good.
Okay. Thank you very much. And what I would like to first say is that we have a healthcare system that has looked after your parents and probably your grandparents. And we should be proud of it. When did it start? In the 1940s, when the government said there should be free healthcare to the people of Sri Lanka. There was no great proclamation, it just came on and people started with free healthcare. And so if you were in the 1950s, if you were ill, you could go to the government hospital and get treatment. You did not have to pay. And as time went on, you had the system working. Doctors were graduating from the only medical faculty then, the Colombo Medical Faculty, and they were getting into the system. We had no medicines or very little medicines that were manufactured in Sri Lanka, and they were, most of them were imported from abroad. Okay, Manuj, would you like to take
Yes,
over
sir.
from there?
I would like to go about 2 decades before to 1930.
Mm.
Actually, most of you may have not read about it. If you look at 1928, 29, 30, and 31, at that period, there was a huge malaria epidemic, particularly in 1930 and 31, where a large number of the population suffered. At that time, the malaria was not only on the dry zone as we saw in the elimination program. It was very much on the part of the wet zone, even in Kegol and other parts of the country. Therefore, actually at that particular time was, I think, the real patient or the community activism started, as far as I have read, in this country on health. We are starting first from the Suryamal Vyapari. If you look at from 1929, 30, 31, from those who came back from education in UK, uh, were N.M. Pereira, then Colin R. De Silva, and a huge crowd who actually took some learning from UK and the Central Europe on how to work on those issues. I think they started this, I would rather say, the community program of Suryamal Vyapari, as it states, which really supported the families and the treatment for malaria. I think that is one of the key things in the milestones of Sri Lankan health system development, where people and civil organizations got together on health front. I think that is where actually, for me, when I would like to say that the civil society and others were really got interested, and that is where the political party, we can't ignore that Sri Lanka Samasamaja Party was built based on the Suryamal Vyapara, and that is the area the leftist movement started in this country, where people were demanding basically welfare policies in the country. And that is exactly as Professor Weerasuriya said, by 1940s and 50s, with this, there was an expansion of basically the health system, particularly starting off smaller hospitals in villages. And that is the health system that we see now. And just one other example that if you have read the book, The History of Medicine in Sri Lanka, two copies are available in the library by Dr. Uragoda. If you read that, in 1854 is the year where the military and the civil health systems divided in this country. 1854, where a separate civil medical department was established. From that day, almost 170 years back from now, is the place where the real Western health system in this country started. All what we see now is a I would rather say the progression from 1954 decision to separate military, which was looking at the British military, and to look at civilian health. So this is how things have gone, and I don't want to take much time. But the students should understand that our system is about 170 years old, basically, if you look at the health system.
Okay. Indika sir, do you have anything to add to that? Or we can go to our next step?
Yeah, I don't have much to add because I think essence was described very much in detail, and I fully agree that the backbone has been the free health policy of the country, which has been there, and the policies and the approaches for the rationalization of medicines that came up during 1960s and 1970s initially. But again, I agree that the foundation was laid long ago, and from the very beginning, over 130 years ago, where the health policies and approaches mainly towards free health, even during that time period. Again, based on the needs of the country, during that time period, the country was hit by many communicable diseases and epidemics, so on and so forth, like the current situation. And there was no option. Basically, the main approach was to go for the free health policy. And if you take the Sri Lankan culture also, if you go even back further in the Sri Lankan culture, in the historical context, health is considered as a priority. When you take the Sri Lankan or the culture or the religious aspect, all these areas, the health profession and the medical profession, and health is considered as a priority, culturally, religious, or otherwise. Therefore, we are the everything works on that the foundation, and all the policies that came up later in 1960s, 70s, they were successful. One reason was that strong foundation due to historical reasons. So I would say the free health, and also to an extent the free education policy and the culture that was based on that has laid a strong foundation.
Okay. So that was about 1950s, 1960s situation in Sri Lanka regarding the healthcare system. So let's move to our next important.
Can I just add one more point? Because if you look
Yes,
at the pharmacology department in in our faculty. So I think it was 1957, I think, when Professor Bibile returned and
A little bit
established
earlier, but go on. Yes.
it's somewhere at that time when Professor Bibile actually returned from his postgraduate training and became the first professor of pharmacology. And that is, I think, the time where scientific thinking on pharmaceutical policies, essential or the drugs, and so those things came into the play in our country. Before that, in 1948, I think 48, there was an act, ordinance on food and drugs related ordinance. I can't remember the exact, the first one in 1948 or 49, which was a very basic structure. But I think the inputs that Professor Bibile was infusing in late 1950s, starting from the formula on for the national or the General Hospital Colombo hospital formula which was started for some other reasons, actually started the policy dialogue on pharmaceuticals, as far as I can understand.
Just I will add one more point. Professor Bibile was the first professor of pharmacology. He was trained in animal pharmacology, but he knew that animal pharmacology is not going to work in Sri Lanka. So he came back and he started human pharmacology. And that is one of the great achievements of Professor Bibile. He could have come back to Sri Lanka, and then, there was an animal house, and you could have taken rabbits and done animal pharmacology. But he said, no, that is not what is important for Sri Lanka. What is important for Sri Lanka is human pharmacology. And as Indika and Manuj have stressed, he looked at how medicines are used in humans and how can we improve them. And that is something that he started, he gave to pharmacology in Sri Lanka, and that is what we have continued. You as medical students would probably not have heard anything about animal pharmacology. All you get lectures is on pharmacology in human beings. And please remember, it was Professor Bibile who started this off saying that is what is important for medical students. Over to you, Chama.
Okay, so that was about before 1970. So now let's move on to 1970s. The period, the climax of the can be considered as the climax of the drug policy implementations in Sri Lanka, and the work of Professor Bibile. I think the work of Professor Bibile towards the healthcare system in Sri Lanka can be discussed at the drug policy point of view and the medical education point of view. So, what do you think about that, sir?
Can
Krishantha,
I
sir?
just add two things before going to this?
Yes, sir.
Because most of you who are here, and I was not born in 1970 or 69, but from what we understand and read, if you look at the latter part of 1960 up to the 1970 election, that period I think is extremely crucial in understanding the political economy of pharmaceutical policies in this country. You know, whether we like it or not, what happened after 1965 to 1970 was a period where there was huge issues on economy. There was a very turbulent period. That is the same period where we now understand is the first rebellion against the government took place in 1971. The breeding grounds of that political instability and issues came in that particular 5 to 6 years period, culminating in 1971. So we need to understand the general thinking process of the community, general discussion points on the community was very much on welfare states, where the government should take a major responsibility in providing services, education, health, and others. So within this type of an political environment is where Professor Bibile was, I think, very instrumental in pushing a scientific agenda within a political, I would rather say, political vacuum and a political um, forces. So this is the time when the LSSP or the Sri Lanka Samasamaja Party was getting and to a combination with then the Sri Lanka Freedom Party to form a government in 1970 elections. So the Samasamaja Party has a major influence who are looking from the people's side and from a welfare side. So within this political environment is that it was possible for Professor Bibile to talk about these issues and others to support him and to push an agenda through the political force. It's just not only a scientific force. Scientific force push through a political activism in that particular, I would rather say, a turbulent period. Okay, thank you.
Just to add a little bit more to what Professor Manuj said, what was important there was that there was an economic crisis. We were, even before the economic crisis, Professor Bibile applied science to what we were doing. He said, look, we are not going to get down all the drugs that everybody wants. We are going to get a limited list of effective drugs. I don't know whether you have ever seen a copy of the Ceylon Hospital Formulary, which was published in 1959. Some of the drugs in the Ceylon Hospital Formulary still are used now. For example, chloramphenicol, tetracycline. But what was significant of the hospital formulary was this was one of the first hospital formularies, not only in Asia, not only in Europe, but in the world. If you look around and say, can we see some more hospital formularies in the 1950s, 1960s? There isn't. So Sri Lanka, Ceylon at that time, had a hospital formulary, and it wasn't a list of drugs. You could look at it and say, yes, chloramphenicol, what is the dose? Yes, this is the dose. Is this a side effect? All the information was there for the doctors to prescribe properly. And that was one of the major achievements of Professor Bibile, in that he not only provided the medicines by making a limited list which was imported by the government for the government sector, but he also provided the information. And this is what I will come to later. You must think of a medicine not only as the tablet, the capsule, the vial, but also the tablet, capsule, and the vial, and the information to use it properly. Over to you, Chamat.
Yes, sir. Indika, sir, can you give us a description about Professor Bibine's contribution to the medical education point of view?
Shamat, I think that might digress a discussion a little bit more. But anyhow, I mean, since you have asked that question, I would give a very brief introduction. I mean, that is an area that is quite unheard. Everyone knows about or talks about, but Bibile has his contribution towards the medicinal drug policies, and that is known worldwide. But very few are aware that he is the person who introduced the scientific practice of medical education to the country during the time period in early 60s and 70s. Yeah, medical education was very traditional and very lecture based, and there was not much emphasis on the newer methods that you are aware or you are going through. So during that time period, Professor Bibile was ahead of his time, and as when he returned as to the Department of Pharmacology and later as a professor in pharmacology, he was very much interested in newer trends and developments in medical education. And it has become more pronounced when he became the founder dean of the new medical school during that time period at Peradeniya. And when he started Peradeniya, he wanted to add new changes, things that he have learned while he was in UK, and the developments and changes in medical education worldwide. So this is where he started the first medical education unit in the country, and started the first teacher training center. During that time period, training of teachers was not considered in medical education as important. If you got the qualification, you are just automatically a teacher or professor. But Professor Senaka Bibile believed that it's very important to train teachers how to teach and use newer methods in medical education. And that's what he has started in Peradeniya. Later, those practices have spread to other parts of the country, and Colombo and later other medical schools started. So in that case, he can be considered as a pioneer in medical education. And probably he has used the same practice like highlighted before. He has used these approaches of student-centered learning, free thinking, into inculcate better attitudes and thinking about medical students rather than taking, like what Professor Krishantha Weerasuriya mentioned, that taking pharmacology as a purely scientific approach. He basically introduced new way of thinking into teaching of pharmacology, into free thinking, and that is something that has retained to date. So in that way, we can consider he as a pioneer in medical education in the country, and that too has indirectly led to the success of the policies that he want to implement.
Thank you, sir. My next question is to Manoj, sir. Sir, can you briefly describe what was Professor Bibile's drug policy and how it continued to and helped to the universal health care in the next 40 years in Sri Lanka? I think Professor Krishant, sir, also
Yes.
can contribute.
Basically, before that, I think because this is a good forum for people to start reading on things. If you look at 1970, after the new government was came to power, there was a assignment for two people to give a comprehensive report on the situation of medicinal drugs in the country, where then the MP for Akuras, S.A. Vikramasinghe, and Professor Bibile was entrusted to do a report, and that is the report that they came out, I think, later part of 1970 and early 1971, is well known as the Vikramasinghe Bibile report. And that report is what we are most of the time referring to as the Professor Senaka Bibile's drug policy, most of the time. It is actually a situation report giving extremely, I think, far reaching thinking and giving a practical way of tackling the issues at that particular time period, giving certain recommendations what we need to and how we need to go forward. And in one of the key things in that is to the government should actually get hold of the pharmaceutical importation and distribution network in the country. To understand that particular recommendation, I will just give you a couple of minutes. At that particular time, if you look at what's happening around the country, from what I have read in the Weerasinghe report and several other things, is that it was mainly dominated by pharmaceutical companies, and there was no much of a serious there were regulations but not real implementation of regulations, and there was no real advantage for the country from the regulations and the important import process of drugs to the country. That is why this particular recommendations came in Bibile Vikrasinghe report in 1970, end of 1970, which at the main I think the implementation point of that is the establishment of the State Pharmaceutical Corporation (SPC). Now it is 50 years. For next year, it is 50 actual years, and this 50 years, SPC has been the main regulator of pharmaceutical prices and practice within the country. Most of the people don't understand that. If SPC was not there, and if PC did not take the major importation part of pharmaceutical in the country, for last 50 years, I think the whole generation should have suffered a lot. Just because SPC is there as a government procurement agency and a distribution network to the government plus retail to the people, they were able to have some scrutiny, particularly on the drug prices in the open market. Because when the SPC, the import drugs on bulk purchase from international tenders, they could bring them the unit cost for a rather low level, which means they can sell those drugs in the open market for a nominal fee. So the private sector found it very difficult to compete with SPC unless some scrutiny or the some sort of a the price regulation is there even within the private sector. So that is a phenomenal issue. So what I want to tell is that Professor Bibile's far thinking process was first look at the procurement, second start on the manufacturing arm of the SPC, which actually started way back in mid 1980s, and actually then buying drugs from outside as a bulk at international tenders where we could buy drugs from India cheaper than what is sold in India in retail market. So if you still look at certain drugs in Sri Lanka, which is actually manufactured in India, is as a lower price in Sri Lanka compared to India in the retail markets. So this is a very far-reaching thinking process where Professor Bibile actually gave us in 1971, and that is how SPC, later SPMC, and particularly the regulatory processes of drugs for quality medicines distribution in the country all came from that particular, I think, report. I would rather advise people who are interested in this whole network to read Bibile Vikramasinghe report of 1970.
Oh,
Krishantha sir, I think your mic is muted, sir.
it's
Now we can sir.
hear me now?
Yes, sir.
Yes?
Yes,
Now,
sir.
Yes.
yes, sir. Yes.
Right. Professor Manuj sort of gave a very good idea of how the medicines came about, how Professor Bibile managed to get them at much more affordable prices than elsewhere. But I'm going to go sideways. And one of the things is there are 119 people participating in this conference. Only 4 people have spoken. I'm now going to ask a question, and can someone please answer that? Professor Manuj said a statement called universal healthcare. Can someone please unmute your mic? And remember, this is not an exam. If you get it wrong, you won't get less marks. What does universal healthcare mean? If you don't answer, I'm going to pick somebody from my screen and say, please answer. Hurry up. I have here Dulan Madhuanta. Can you please answer that question? What is universal healthcare?
Something like universal standards between the globally in the hospital sector, like something.
Thank you. But that is not the answer. universal healthcare is that anybody in the country will get healthcare. Full stop. You are a prisoner, you won't be told, no, you are a prisoner, you won't get healthcare. You are from the eastern province? No. You are from the eastern province, we don't give healthcare. You can see that in the hospital. When you go into the hospital, you are not asked your background. You are just asked, nama, vayasa, and then you are treated. So universal healthcare means healthcare provided to everybody. I'm going to pick another question quickly. Do you think universal healthcare is common in countries like us in the developing world? Shall I pick a name or is somebody going to give me the answer? There is a Manelka Vitana. What is the answer? What do you think? Hurry up.
I think in most of countries they
Most of the countries. Go ahead. Yeah. Is it common or not?
they give
They give. Right.
but not for all.
This is a halfway answer question. Most of the countries they give, not for all. No. What are the countries that give healthcare for all in our part of the world?
Cuba.
Cuba, right, fine, but that's not our part of the world. Yes, I agree with you. Cuba is one. All right, I'll give you a list. Pakistan? Yes, no, quickly. I'll give you the answer. No. India? No. Myanmar? No. Bangladesh? No. Right? If you go to Bangladesh, and fall ill, you can't just walk into a hospital and get treatment. Whereas in Sri Lanka, universal healthcare means even tourists get free healthcare. Okay? Now, why did I talk about universal healthcare? That is because Sri Lanka has it and very few people really understand that. What is the connection of universal healthcare to the the drug policy that Professor Bibile has talked about? If you look at the Sri Lankan government healthcare system, what do you think is the major expenditure for the government healthcare system? Is it the salaries? Is it the buildings? Is it the medicines? Is it the equipment? What do you think is the major expenditure? Somebody quickly. Sangeeta Mohan.
Medicines. Medicines, sir?
No. The number one, more than 50%, is what you all are going to take when you become doctors. It is the salaries, okay, of any healthcare system. It is the salaries. Number two is the medicines. And this is why Professor Bibile's policy was important. You couldn't do anything with the number one. You had to pay the salaries for the doctors, a reason. Not only the doctors, the nurses, pharmacists, technicians, everybody. But he took the second one and he did what you call rationalized. He said, no, we are not going to import 28 vitamins. We are going to import only 3 vitamins. No, we are not going to import 3 brands of tetracycline, 1 brand of tetracycline. So as a result of that, what happened is the medicines cost in the system went down. Why this is important is a lot of systems have failed because they couldn't control the medicines cost. Sri Lanka was able to control the medicines cost. And it has controlled the medicines cost for the 50 years, right? And so this is what is important, that Professor Bibile took a problem that was there, which was lack of foreign exchange. None of you were born in the 1970s, but I can remember they used to say, okay, no money to import this. You will have to stop the imports of these. But medicines were imported because Professor Bibile managed to decrease the cost of medicines by his national drug policy. And that is the beginning in the 1970s of actually, we talk about the policy and what it does, but this is the practical thing that came in and said, here you can see a benefit of a policy improving the healthcare system of the country. Over to you, Chaman.
Yes, sir. Sir, I think we should talk about the resistance that was built when Professor Bibile tried to implement the policies. So, any thing about that, sir?
Yeah, I think it's a very interesting question. Was there a resistance to the approach of Professor Bibile during 1970s? Probably the obvious answer is yes, and the expected answer is yes. When someone tries to control and probably control the prices of a very profitable industry with a lot of international powers coming in, the obvious answer is yes. And we would expect the resistance to be very much violent and maybe very much pronounced and prominent. But the reality is the resistance was more hidden or more indirect than direct. There are several reasons. One thing that we have to remember is there will be resistance against any kind of progressive movement. However, that resistance depends on so many factors. It's very complex and it's very dynamic. And that resistance will change with time. It may be more, it may be less. One good example is that, say, if you take privatization of medical education, the resistance that was there in maybe 1980s was different from what was seen in maybe 2000 or 2010. It changes with time. Similarly, here also, you have to think about many different factors. One is the state sector, the government and the policies. Other one is the global situation. Other one is the pharmaceutical industry. And then the socio-economic and the cultural situation and the medical profession. And finally, the patients. If you take all these different factors interplaying, it's very obvious that they can be very complex. Those interplays can be very complex. So if you take the situation that was in 1970s, is obviously much different from what is there in now in 2020. However, like Professor Krishantha Weerasuriya very correctly mentioned, the approaches during that time period has managed to bring down drug prices, make them more affordable and available. And even to date, the elements have remained. Even now, even if you take the current situation, the context has very much changed. Even to date, the drug prices are comparably affordable and available. So there must have been some success in this approach. How we can see this success is that the question that you answer. Were there resistance? Yes, there was resistance, but it was not much. Why? One reason was, like Professor Krishantha Weerasuriya mentioned, during that time period, there was a global recession and economic downturn with a lack of foreign exchange. So during that time period, the government was anyway compelled for rationalization because foreign exchange was very much limited. If you take the global situation also, during that time period, the movements were more towards non-aligned. You must have heard about the Cold War time period with two distinct camps. And then there was the non-alignment movement. And Sri Lanka was a leader in the non-alignment movement. And the country also, due to the political changes in 1950s and later 60s and 70s, the documentations very clearly mention that there was more trend towards more socialist and people-oriented policies during that time period. So government priorities were different during that time period. They were more towards nationalization and more people-oriented. And if you take the medical profession, again, yes, there was a difference. I mean, partly the private practice-oriented medical profession was more supportive towards not rationalizing. But at the same time, due to the changes in medical education that we have mentioned, the policies and the people-oriented policies, there was a thinking trending towards more people-oriented healthcare, and that was supported by the free health policy of the country and the free education policy. So that was also a positive aspect. And one would obviously expect the pharmaceutical industry to be vehemently against. But again, that was not the case. Again, many reasons. If you take the Sri Lankan market during that time period, was a smaller market and not much opportunities for investment. And the government policies were straight more towards the private, towards the public orientation and people-centered approaches. And no industry would straight away oppose the government policies unless there were some discrepancies or some direct issues. But if there's a government policy related to rationalization, then the resistance will not be direct. And many other reasons. Now, if you take the health policy or the health system in Sri Lanka during that time period, it was mainly government oriented, with the state sector taking the major bulk. Even to date, if you take the inpatient care, most it is government oriented. So, if the government decides that the supply should be mainly through the government system, then the pharmaceutical industry would have to abide by that. If you take the SPC is the main supply of the government health system. Therefore, other systems will have to fall in line. True that there was resistance, but it was mainly through diplomatic pressures and indirect pressures at the government. And the government situation also, as I have mentioned previously, during that time period, it was more people oriented. But later, with the economic recession coming in, and there was again, Professor Weerasuriya mentioned about that, the food crisis, that has changed the government approach, because government had to be dependent on other countries, especially the United States. So therefore, the government was compelled to yield into that indirect pressure. So what I'm trying to say is, it's a very complex situation. And the resistance that you have mentioned, it was there and it is there. Even now it will be there. But you have to look at it from the change in angles. Later, the 1970s government, because of the pressure, the government composition also changed from the more people-oriented approach. And because of that, they have to relax some of the initial rationalization policies that they have been following. So you can see how the systems are changing. Then again, some of you may be aware of the government change in 1977. The 1977 government was more people-oriented, but because of the difficulties, there was resistance of the people coming in. And people were calling for more open economy, more free market economy, so on and so forth. And that has changed in 1977. And then more opening up of the economy has happened. But again, one thing that we have to take a notice, even in 1977, the SPC monopoly or SPC authority on the government supplies was not relaxed. Even during that government, which has followed a completely opposite trade policy compared to the 1970 government. Again, we can relate that to the culture and the health system in Sri Lanka. Whatever the government, Sri Lankan health system is based on the free education and free health. So that policies have stood. Even to date, I think those ingredients have stand. So even to date, even with a lot of changes in the context, the reasons for even the elements of the rationalized drug policy and the price control remaining even to date. Even now, people are talking about sustainable policies and the approaches, and they are basically very much appreciated. Why? Because all these are based on Sri Lanka's time-tested approach into the free health system. So what I want to say is, yes, there was resistance, there will be resistance, but we have to look at this very complex interplays based on the context. I think Prof. Weerasuriya, if you want to add into that.
Can I just add one thing? When it comes to resistance, as Indika was talking, there were resistance from outside as well as resistance from inside. What I'm talking about inside is from the profession itself. If you look at the medical fraternity, to combat resistance from outside is relatively easy compared to combating the resistance from inside. If the medical fraternity opposes rational policies, because these are the people who are going to implement it within the country. So if there is resistance within the medical profession itself, it's very difficult to combat that compared to what is happening outside. If the government have backing from the whole of the medical profession, then they have a stand and a foundation to work with the outside resistance. But when the inside of the profession is divided on an issue, then the government or the authorities find it very difficult to establish a platform to resist what is coming from outside. So this has to be looked at. I think that is exactly happened. If you look at from 1975-76 area, where there was political again turbulence in the government itself, where 1975, end of 1975, Professor Bibile, Professor Bibile has to leave SPC and even the country because there was more resistance within than from outside.
Yeah, Manuj, if I am to add, I think this inward resistance is something that you have to really understand because that is a fact. I mean, it happens at all levels. For example, now, as students, now you are working in Sirha. Now, if you want to initiate something or some activity related to rationalization drug policies, there will not be direct resistance because in Sri Lanka, culturally and over time, it is considered and taken for granted that rationalization of drug policy is a good thing. It's a people-oriented thing and something that we have to do. It is on the basis of the free health system of the country and the free education system of the country, which has been embedded into the mindset. So no one will be directly opposing. But at the same time, there will be a lot of indirect opposition from different parties that can happen. Another interesting that I want to mention is that if you read the Sanjay Lal and Senator Bibile paper, 1976 paper on drug policies and how the combating the transnationals in a Sri Lankan context, they have identified those different players. And they have identified the medical profession in Sri Lanka during that time as one of the major resisting force, again due to reasons related to the commercialization and privatization. But at the same time, there were some doctors who were supporting. So again, this inward resistance and the hidden resistance is something that we have to expect, not the direct one.
Krishantha, do you have something to add to that?
No, go ahead. I'll make a very short this thing. In fact, some of you will hear what was heard 50 years ago, even now. You will hear some people saying, oh, generic drugs are not good. It is the brand name drugs that are good. There is no evidence that if generic drugs are manufactured correctly, they are as good as the brand name drugs. And this is a story we heard in the 1970s and has continued and continued. The only thing I would tell medical students is when they are told that, to say, why do you say that, and question it. Then in that case, the people saying it will understand that this katakatava that has come through generations is now being resisted. Over to you.
Since we talked about the situation like that, let's talk about the present day, about the drug policy in Sri Lanka nowadays and the modern pharmaceutical industry and its relationship to the medical profession in Sri Lanka. I think Professor Krishantha has.
Okay.
Yeah.
Let me again ask questions. There's now still quite a lot. What is the major issue, health problem that is facing the world now? Easy question. Quickly, somebody answer. What is the major issue? Ravindu Prabhasara, go on quickly. Unmute yourself and give me the answer. Are you there? What is the major health problem? This is not a difficult question. That is facing the world now.
Non-communicable diseases, sir.
No. Now, today,
COVID-19.
COVID-19, full stop. That is the major problem, right? Yes, non-communicable diseases will kill the people or affect the people in 10 years' time. But today, it has created a lot of problems. So now you think, okay, now COVID-19 is a major problem and we should be doing something about this. And so who can do something about it? It would be the pharmaceutical industry who can actually develop a new drug or develop some new vaccines. Do you agree with that? I would think so. So then when the pharmaceutical companies were told, okay, now you are the people who make vaccines. Now, can you get into this and make a vaccine? Their answer was, that is a very risky thing. If we try to make a vaccine and it does not is not come out properly, we will make a big loss. So what you got to understand is that the industry will look at it as a business and then decide whether it is worthwhile going in or not. Why did the industry now start getting involved in vaccines? The billions of dollars have been provided to the industry by the governments of the United Kingdom, the USA, Germany, all those who have said, go and start a vaccine. So the industry then said, okay, fine, we've got a lot of money that we can risk. If it doesn't work out, major problem, but it's not our money. So that is what you got to understand, that it is an industry and they will focus on profitable opportunities. Okay? Now, all of you have heard about malaria, correct? Yes. None of you have seen a patient with malaria in Sri Lanka. That is also correct because Sri Lanka has eradicated malaria. Now, who are the people who discovered the medicines to cure the malaria? Was it the pharmaceutical industry? No. It was from a Chinese plant. Why was this? There were millions and millions of patients with malaria, but the industry wasn't interested. Why was it not interested? Because it was all in the developing world. There wasn't a market. So if we spend money, and even if we get a good drug, we can't sell it for a profit. We might as well go and make drugs that are profitable. Like, for example, if people are having white hair like me, if we make a drug that will stop the white hair, we will make a big amount of money. So there was much more money spent on these things than treating malaria. Now you can see the underlying basis for this. Now I'm going to come to you and ask you, you medical students, a question. Most of you have heard of Omiprasol, correct? Yes, you are in Chamat, is that correct? Just nod your head. You all have
Yes,
learnt
sir.
about
Yeah,
Omiprasol?
yeah.
Right, okay. How many of you have heard of Pentapresult? Some amount? Okay. I'm going to ask Chamali, what is the difference between Omiprasol and Pentapresol. Do you think you can tell me, look, I don't know, or do you think you know the answer? Chamali is the name that I see here.
Actually, I don't know, sir.
Okay, fine, good. But what I wanted to tell you was that Omeprazole was the first drug of that class that came. Then after that came Pantoprazole and all the other prazoles that are there. And if you look at the difference, there is no difference between Omeprazole, Pantoprazole, and all the other prazoles. What is the point I'm making? The drug companies will look at one drug and say, okay, we know there is a market there, so we will make another drug that is similar to it. We will make the third drug, we will make the fourth drug. These are called me too drugs. If you go and tell them, why don't you make a new drug that is useful for conditions like Alzheimer's? Oh, no. We don't want to do that because we'll have to spend a lot of money and might not work, and we will not make any money on that. So that's what you got to see, that the industry is particularly not interested in the health as such. It is interested in something that is profitable. And this is where you come in as medical students and when you graduate as doctors, that you must know how to get good information of drugs. And when somebody says drug A is better than drug B, to check and see, is this correct? I will ask the final question. Right, let me pick Bhagya Disanayaka, right? What is the best source of drug information that you can get so that you can make this thing? Tell me. Bhagya Disanayaka. I see that person in front of me. Go on. Just quickly tell me whether you know a good source of drug information. No? Okay. All I wanted from you was the words called the British National Formulary. Right? Now I can see a few heads going up and down. There are over 90 people on this, and I hope at least half of you have the British National Formulary on your smartphone. It is much better than Facebook and Twitter and anything. That gives you the best information. And this is where it comes in, where you as medical students will talk about policy later. But if you want to advance Professor Bibile's work, you must learn about medicines and their information. And the best one that is available for you is the British National Formulary. So just to tell you very quickly, treat the industry as an industry. They are never the friends of the medical profession. Neither are they the friends of us poor countries. Look at what they say and use good information to evaluate what they say. And that is how you will treat the industry and see that the industry will finally, they will be in the thing of making profits, but it's up to you all to use their products correctly. And if it is good, yes, you make money. If it is bad, no, you don't make money. Thank you.
Can I just have a few points here? As Sir stating, I think there are diseases across the globe. Some of those are infective or the communicable diseases, so which are categorized as neglected diseases. And actually, sir is working in relation to one of the key organizations who are looking at that. Those neglected diseases are diseases where the major companies and others are not interested. As I said, that they don't, they if they invest in those areas, they do not see a return for the investment, a large return for the investment, because these diseases are more or less in developed or developing countries in Africa and Asian region, and certainly in some of the South American countries, where they will not buy drugs in the high cost. Therefore, some of the industry, looking at the return for the investment, is reluctant to invest on those. So there are many diseases. Some of the examples are malaria. Now TB is a huge issue. So these diseases, you don't see new drugs coming to the market frequently. But if you look at some of those non-communicable diseases, there are certain drugs coming regularly into the market, but many of them are Me Too drugs, as Prof. Weerasuriya was explaining. Because the average patient in a country like ours cannot afford to the so-called innovative brand, which they have about 20 years of patent, but within that 20 years they can't sell those drugs to most of the patients in our part of the world, because we cannot afford to buy them. So they don't see a good return of investment, even if they actually spend on that. Same thing for certain vaccines, because vaccines are expensive stuff, and average patient of a country like ours cannot buy it over the counter or pay over the counter for something like that. Therefore, they do not invest on that. So whatever said and done, pharmaceutical industry is a profit oriented industry, and their profit margins are very high. Therefore, they will not actually look at areas where they can't actually get uh, high profits. That is one. Second one, as Professor Weerasuriya mentioned about the BNF, I offer 50 pediatric BNF copies to Sira. If someone comes on, I think, Friday morning, I will offer 50 pediatric BNF copies of 2017, I think I have, which I got from donation from UK. Some of the books I want to send to some of the hospitals to pediatric wards. I will offer 50. If I have more, some more to Sira. So you can have a handy copy with you.
I will come, sir.
One quick bit of homework leading from Professor Manuj's talk. We talked about drugs for neglected diseases. There is a condition called sleeping sickness. No, you would not have heard of it in your lectures because there is no sleeping sickness in Sri Lanka. Yes, of course, you all get sleeping sickness during lectures, but that is not the sleeping sickness we are talking about. There is a parasitical condition called sleeping sickness. A new drug for it has come out. Go and read it up on the internet as to how a new drug for what is for the poor people in Africa came about. Was it because pharmaceutical industry did a lot of work, or was it because others did a lot of work? But it will give you a good case history of the industry, and as Professor Manuj mentioned, drugs, neglected diseases.
Okay. I have a question to Manuj sir. Sir, this is one of my first-hand experiences. I have heard people saying that SPC drugs are of low quality because most of them are imported from India. Is this true, sir? Is there a rationale for this?
Very good question. How many patients are treated in our government hospitals per year? Inpatients. how many patients who come to the OPD are treated at our OPD per year? What drugs do they get? The drugs which is been distributed to the government hospitals are drugs which are procured by the SPC. Because just giving two things, the MSD is the Medical Supplies Division, is the branch of the Ministry of Health who finally actually do the job of estimating the requirements of the whole of government for medicines. And it also has a distribution network. And when they get that estimate, they forward it to the SPC to procure every year. Where does the SPC procure drugs? They procure drugs from mainly about 4 countries or 5 countries. The major bulk goes to India. There are drugs taken from Bangladesh. There is some from Pakistan and Indonesia. And there are other drugs which are small quantities which is not produced in those countries are taken from other places. We are telling that our health system has a very good output in the government sector. If those drugs are of poor quality, then can the person who is in the cardiology unit look at around the faculty, the patients who are attending LRH, mothers who are coming to deliver at DMH, and all the medical clinics in the NHSL and all other hospitals. The patients get drugs which are procured by SPC through international tenders and in bulk procurements. And majority come from still India, Bangladesh, Pakistan, and Indonesia. If people don't get cured, if people don't get control of their blood pressure, their sugar levels, their lipid levels, then there is a case. But the issue is not that. We see people are kept healthy by giving these drugs. So these drugs are coming from India. So as sir actually said sometime back in this discussion, in 1970, when the SPC was started, this allegation was there. When 77, this allegation was there. In 1990, when we actually, we started to be medical student, 1990, 1991, we heard those. When we got out and started practicing in late 1990s and 2000s, it was there. The same thing came in the final meeting which was held for the drug policy, which is enforced now in 2005. The same arguments were coming again and again during that particular meeting 2005, which was held at LRH auditorium. And the same things are said in 2020 now. So what is the basis, as sir said, question, and they don't have a basis to say. The only issue that I have is to have good quality medicines into a country. We need to have a good regulatory framework, good actual testing facilities, and good post-marketing testing facilities. So if post-marketing testing facilities are not well developed, it's not into the drugs for India, Bangladesh, UK, or any other country, the same issue could happen. If you go to the FDA website, Food and Drug Authority website in USA, how many drugs are being removed and put in their web stating that these drugs are removed because of low quality time to time. So if it happens in USA, it can happen in Sri Lanka. But it does not mean that drugs from India or somewhere else is inherently of low quality. I hope I answered your question.
Yes, sir.
Let me quickly tell you a story which is connected to medical students so that you might be able to become popular with your elderly generation. generation. There was a medical student who came and spoke to me after a lecture and said that his uncle was taking this medicine and it was very expensive. And the uncle said, can we do something about it? And he showed me the drug, and that was an expensive brand name drug. So I told him, find out the generic name, go to Asusala, and then see whether you can get the drug by generic name. And he found it, and that was only 20% of the cost of the brand name. He then said, give me the money, I will purchase this drug and then bring it for you. And the uncle said, after taking that generic drug, which was 20% of this thing, oh, I see no difference. My blood pressure still remains the same. Why have I been spending so much money for this expensive drug when I could have got the same thing from this generic drug? And that boy became the favorite nephew of that uncle. Okay?
Okay, thank you for that descriptive explanation, sir. Okay, I think we have gradually come to the final part of our discussion. That is to talk about the responsibility of medical students as medical students and healthcare professionals. What is our role? Our role regarding the patient-friendly drug policy in Sri Lanka, but actually, Indika sir, Manuj sir, and Krishantha sir may have a lot to say in that. But before that, I have to make a special announcement. In the audience, we have a special guest, the second son of Professor Senaka Bibili, Mr. Ranil Bibili. Sir, are you there, sir?
Yes, yes. Can you hear me?
Yes, sir, we can hear you. Welcome, sir.
Thank you, thank you.
Yes, I think you are joining from Canada.
I'm joining from Vancouver, yes, in Canada.
Okay, I think.
Okay, hold on. I'm just trying to see if I can get my camera going. Yeah. I did what Mark Zuckerberg does. I put a tape over my camera. I think. Let's see if you can see me now. Your camera is not launched properly. Okay, forget about the camera. Yes, I just wanted to add a few things, if I may. When I first came here and I went and saw a doctor for the first time, it was a wonderful surprise to see that all medicine here is prescribed by generic name and not by brand name. Okay, because Canada has been following the same policies that my father tried to implement. And Canada is a free market economy. Yet, first of all, we have universal healthcare, which is free and is the same whether you're a millionaire's son or a store clerk's son. And that medicine, for example, there was a medicine I picked up in Sri Lanka, which comes, unfortunately, I can't get my camera going, but it comes beautifully foil wrapped, each individual capsule in a nice silver foil wrap. And comes in a nice box, all very expensive packaging. I don't know the cost relation between the packaging and the actual cost of the tablet. But when you get the same medicine here in Canada, you just get it in a plastic container from the pharmacy in loose tablets. Because the government buys, each province manages its health system, but each province's government buys annually all the medication by international tender. So they get it in bulk and then they give it individual tablets to the customer, to the patient. South of the border in America, of course, it's a completely different system. And I had an experience where I was visiting the US and had a medical condition for which I had to be hospitalized for about 5 days. And came back and I got a bill for 5 days, a bill for $100 and something thousand. Luckily, the insurance paid for it. If not, I would have been bankrupted. And I came and spent another 2 weeks in Canada, in hospital for the same condition, and I had to pay, not even pay $1. Okay, so this is what universal healthcare is, and life expectancy in Canada is higher than in the United States because of universal healthcare. And recently, you all were talking about COVID. We had some footage from the US showing that people with symptoms are turning up in hospitals and not getting tested because the cost of the test they can't afford. So Sri Lanka in Asia is, of course, like a lamp, as the doctor in Australia said. And Sri Lanka is lucky because of that universal healthcare. That's what I want to say about government tendering, the labeling of drugs, and of course the free. Even for prescription drugs, there is a thing called fair pharmacare, where if you register with that, your maximum you'll spend for a year is $100, and beyond that, everything is paid by the government, even for even for patient prescription medication. And by the government tendering on generic names, I think we save about, and in British Columbia, where I live, saves about $500 or $600 million per year. That's what I wanted to say, Ken.
Yes, sir. Thank you very much, sir. We'll get back to you again. My question is to Indika, sir. Sir, as medical students, what is our responsibility in regarding the continuation of the drug policy in Sri Lanka? What should be medical students as what should we do? Indika, sir, are you there, sir?
Or shall I start off?
Yes, sir. Yes, please continue.
We have talked about drug policy. You are medical students waiting to graduate. What is your responsibility for drug policy? And what I see is that you are the young of the profession who will become the middle people and then finally the senior people. Your primary responsibility is actually using drugs well. That is a part of the Professor Bibile policy. Using to know what a drug is, and generally in your area, most people will say there are a lot of drugs, but generally, if you go and look at a doctor who is practicing, he at the most uses about 30 drugs, even the specialist, and then maybe goes on to 50 drugs. Doesn't use all 200, 300 drugs. So point number one, get to know the drugs that you are using well. What is their dose? What should be the side effects? As importantly, what do we tell the patient when taking the drug? Tell the patient at times, when you take this drug, you might get a bit of heartburn. That's okay. Do not worry about it, right? Or tell the patient, if you get a mild diarrhea, then the patient will say, I was warned about this. Let me see. If the diarrhea continues, I go back, but it's a mild diarrhea, I can forget it. So the first part of, if you are to follow Professor Bibile, is to know your drugs and use them well, using good drug information, as I mentioned, the British National Formulary. The second part of doing about Professor Bibile is his policy of rational drug use and taking it. If you are in a hospital, then in that case, in the formulary committee, there must be something which says what are the drugs we are buying, what will we be using, and trying to use a rational drug policy. That is what you can do as prescribers. But if you then go on to an area where you are a more decision maker, you are bigger than just a clinician, then in that case, the principles of what Professor Bibile has said can be implemented. So that's what I have to say for students who think about Professor Bibile's policy. The first part is knowing your drugs and using them well is the most important. Second is when you have a chance to talk about it, to influence how drugs are used and to promote rational drug use. Okay, thank you.
Thank you, sir. Indika, sir, are you there?
Yes, yeah, Shamat. Yeah, I think related to the responsibility of the students, and one positive thing that I can see among all of you is that you are very passionate about it, and all of you want to make a change, and probably do something that would benefit the masses. So my suggestion is, yes, that's very encouraging that medical students being very altruistic and very passionate about the services that you want to do to the society. The way to do it, like Professor Krishantha very correctly mentioned, develop your technical competency. It's very important to be passionate and really like what you want to do, but make use of the same passion that you are having and the interest that you are having and the motivation to be technically competent, because it's very important for the work that you want to do as Sirha and maybe as future doctors. It's very important to be technically competent and to be very thorough about the knowledge. I'll give one example. Now you might find a pharmacology areas like pharmacodynamics or pharmacokinetics or some of the details about the drugs very boring. Or if you think about community medicine, again, you might find it rather boring. But since you are very passionate about how you can make a change in a society, make use of that. Make use of that fire within you to get the technical competency, because it's very important for you to be competent. Not just, I mean, it's not just enough to be compassionate and passionate only or motivated only. That's a starting point. But be so good in your technical competency that you can never be challenged. You should be able to discuss and argue in any forum. And you will not be able to do it unless you are technically competent, unless you are knowledgeable. So make use of your passion to know about these finer points and be very, very competent technology, have good understanding about the theories and principles, but make use of these theories and principles for the benefit of the masses. Again, as I have said, one example, a system in Sri Lanka can be very boring topic, but you have to learn about the system in Sri Lanka if you want to make a change. Pharmacokinetics and pharmacodynamics can be very boring, but you need to learn about how drugs act if you have to make rational decisions. So whether you are going to be a physician, surgeon, or whatever specialty, I think having your ideas is very important, and having your principles, strong principles, is very important. At the same time, those principles have to be supported by strong technical competence. So that is my message. Be very strong technically as well as knowledge-wise. That's also part of your responsibility.
Thank you, sir. Manuj, sir, what is your opinion?
Just couple of things. I think Professor Weerasuriya very clearly stated the direct responsibility of students, and they also stated how you should respond as students. I would add 2 or 3 things. How conscious you are on the prices of medicines. Because when we are participating in integrated ward class or when students come with a prescription which is given to a patient, most of the time I'm asking them is, have you looked at the cost of this prescription or this regime? It's not only the drug and its knowledge about that pharmacokinetics, dynamics, and side effects, and so on. The cost of a prescription, cost of a drug, and are there alternatives that this person can afford to? You are not prescribers at the moment, but this understanding and this exploration helps you to get a knowledge whether people can really afford. We can write prescriptions, but will a person comply with this prescription to the last date? Because it based on sometimes the affordability. And if you are not totally unaware about the cost of the drugs, it's another drug for you, but it's not another drug for the patient. Patient has to take it and to afford it. For example, if someone has given a prescription which takes about 2 or 3,000 rupees per week, then which means that it's very likely he will not take that drugs. That is one. Second one thing is he has to spend what he has to spend on food on drugs, or what is has to be spent on his kid on the drugs. So this awareness is extremely important if you can inculcate from now on. Because when you go to wards, when you go to a college, when you go to the community and person is giving you that these are the drugs I'm taking, so when you have time, just get into a pharmacy or just go to Osusala and check how much a prescription really costs. And is there alternatives for those that would be less expensive and affordable to people? And from our side, actually, we did in a lot of time when we were students, which gave us some real understanding the affordability and the range of prices. That is why still we are advocating this. That is one. Second one is, as a medical student, when you go home, when you go to a boarding house, or when you meet some of your school friends, they ask you about drugs, conditions, and so on. So as both Professor Weerasuriya and Professor Indika stated, unless you know your stuff, you are not confident enough to provide them with good explanations of medicines. Because most of the time, people will ask you only two things. They will ask some detailed understanding of a disease, and secondly, a drug. So if you study those, you will be very confident in giving correct information to others. That will definitely benefit a large section of the population. That is second. Third one I would like to tell is that you have the opportunity of looking at drug advertisements. There are so many things going around, even in colleges, even in science, medical journals, and so on. When you get an advertisement, at least one advertisement for a week or one advertisement for 2 weeks, just get a BNF. If you have the opportunity, get to the library and get the larger books, textbooks, and just check how accurate is the information given in this particular advertisement, which will give you a very good understanding about the drug. And this is much easier than studying a textbook. You are practically applying your knowledge to learn about drugs by looking at advertisement and trying to analyze it, so it will remain in your mind and in your memory. So these three things are extremely important. The fourth one, what I want to tell is that whatever the knowledge you get, you have to retain it and you have to practice it. Unfortunately, what we are seeing is the knowledge is given in the pharmacology lectures and therapeutic lectures. You read for the exam, but to what extent you will retain it when you are going to practice it? Will the medical representative dictate you in your practice, or can you actually use your general understanding what you have taken from textbooks when you are going to practice? So if you get these four, I think you have done your job.
Thank you very much, sir. Before conclusion, I would like to ask Mr. Ranil Bibile, as a non-medical person, what is the message that you have to give to the medical students or students who will be healthcare professionals in the future, sir?
To be sympathetic to your patient and to the population, and to we're talking about a rational prescription of pharmaceuticals or medicine. So you have to be rational in all aspects of what you do in treating the patient. As you said, you have to consider the whole dosage. Can he afford it? I mean, I remember so you have to be father saying situations where patients go to the pharmacy, what you do, and they find the price, and instead of taking the full dosage, they just buy half of it, thinking that half is going to work. And with antibiotics, the danger of it that the pathogens will develop resistance. So all this has to be taken into. In Sri Lanka, I think anybody can sort of walk, if you're properly dressed, you can walk into a pharmacy and buy prescription drugs over the counter, right? And that is a big danger. But also the Ususala, when you go, of course, there are queues and maybe they don't have enough outlets and so on. Sorry, your question was about what, right? And that is a big danger. What is the advice to the young people? You have an opportunity with free education there for medical students to study. Now you got to give something back to society, having received the free education. And that is the advice to the young doctors. You have an opportunity with free education, prestige over there because everybody feels to study to society, having received. But that's not ultimately, as we all want to make a decent living, but should not be your primary focus. When my father went into teaching, he told me, relations sort of said, well, why do you go into teaching? You should go into private practice because that's where the money is. But he was not interested. He really wanted to do something. And so he went into teaching and research and the whole pharmaceutical aspects of his career. I think that's what I have to say. It's morning here in Vancouver. It's 8 o'clock, and I do have to go out. And so he went into teacher panel, the eminent panel, for organizing this timely Zoom presentation on the occasion of my father's death anniversary. Thank you, everyone.
Thank you, sir. Thank you very much for joining. So in today's discussion, what we talked about was how was the drug policy in Sri Lanka persisted in 1950s, 1960s, and then in the 1970s, what
Zoom
were the
presentation. Sorry, this question is being addressed to the panel.
I think there was a connection problem. So yeah. If you are not feeling,
Yes.
You can continue, sir. Hello. So I think there were some.
Yes.
Yeah. connection problem. You answered the question I asked about, sir. Uh, okay, I will carry on. Um, so we talked about 1950s, 1960s drug policy, and in the 1970s with the political changes and what happened and what Professor Bibire tried to do and what he achieved, and then how it continued for the next 40 years. And finally, as medical students, what is our responsibility in establishing a patient-friendly drug policy? So we have sort of come to the end of our discussion. If the audience have any questions regarding the content we discussed, you have the opportunity to ask from our guest speakers. Or you can unmute your mic and ask, or else you can put them in the chat box as well. If you have any questions, please ask. So, there is a question asking, is there any regulations for the doctors with regarding the pharmaceutical companies? Any rules or regulation about promoting the brands and all? Can Krishantha sir or Manuj sir, Indika sir answer it?
Okay, that is a good question. How can we regulate the doctors who will prescribe correctly? That is an extremely difficult situation for which there are examples, but most of the examples are examples that have not been successful. But on the other hand, in Sri Lanka, I can tell you, well, I will start with a few successful examples in Sri Lanka. In the government hospital, if a person writes a prescription for propanolol or whatever, a beta blocker, writes by the brand name, and it is given to the government hospital, the government hospital will say, no, we don't have this brand name. We are going to give you the generic. So in the government hospital, whatever brand name you write, if it is available, and it will be available by generic name, that is what will be prescribed. There is no regulation that simply says, okay, you must give the generic. It is simply, this is what the pharmacy has. This is what the pharmacy will give. Now go into the private sector. If a doctor gives a prescription with a brand name, first of all, the doctor is supposed to write a prescription with the generic name first. There are at the moment 59 participants, 58 participants here Out of that, there must be at least 50 medical students. I hope you will remember that your scientific is what you do as a doctor. For it to be correct, you must write your prescription by generic name. And that is what the government tells you also. But all of you know, having looked at prescriptions in the private sector, they are written by brand name. So can the government go and then take action? The answer to that is it is not possible to run after every doctor and make them prescribe by generic name. So as a result, this is not a regulation that can be enforced. But as Mr. Bibile said, remember, when the government has a control, it will then do what the government wants and not what the doctor wants. Unfortunately, when the doctor has a control, there is no way it's very difficult for the government to control the doctor. They will say that the doctor has said that this is the drug it must give. But that is not exactly correct. One of your medical students made a very nice statement in which he said, when the one who decides, who is the one who decides? It is the doctor, does not pay, and the one who pays, who is the one that pays? The patient, does not decide, then proper rational prescribing will not be done. So to go back to your original question, the government has regulations, but they are difficult to interview this thing. And the only successful thing that we have seen has been where the government controls the supply and provides the medicine. As you heard from Mr. Bibile, Canada, government controls the supply. You can write any brand name you want, but you will be given the generic. So that's the way of controlling it. Not a very clear, not a very satisfactory answer, but that is the situation.
Sir, there's another question in the chat, sir. If Manuj sir or Indika sir can answer that. I think this is regarding the pharmacist's point of view, I think. Yes.
The issue is here we have registering too many brands and branded generics in this country. If you look the drug registration policy, if you have 3 or 4 equivalent drugs registered, then things are extremely easy. For paracetamol, there are 4 paracetamol generics or brand or whatever. When you have about 60 registered under the NMDR and about 10 or 15 in the market at a given point in time, when you go to a pharmacy, that pharmacy may not be having the brand name or branded generic which is prescribed in that particular pharmacy. And that is where this particular questions come in. But in the actual regulations, in our medicine acts, everyone has to write in generic. And if necessary, you can write the brand name in parentheses. That is the regulation. The issue is there are so many brands and branded generics in the market. Different prescribers prescribe different brand names or branded generics, maybe about 10 or 15 if you look at paracetamol, and a given pharmacy may be only keeping 2 or 3. Then they would say that we don't have this. Can I give another brand or a generic or a branded generic? If when our registration process is done in a way that all these are tested and all these are given equal standard, then there is no issue what is being prescribed and what is being given. The issue here is that if the pharmacists have the authority to give a medicine that is not written but maybe a generic or a branded brand of the same medicine, I think that flexibility is there particularly. But on the same line, if you look at the regulation we have in this country, if you do not have something, then the pharmacist should tell these are the things available with me and these are the prices available and the patient could choose. But as Professor Weerasuriya very clearly said, although the regulations are there, in practice, implementing those are very difficult. The person who goes from prescription think the doctor has written the best drug for me and he does not want a substitution drugs to be given to him. So this culture is created by no one else but the medical profession. If the medical profession or the prescription doctor write in a generic can state, this is I have written in generic, this would be some 30 cents a tablet or 2 rupees a tablet, and you can get from any pharmacy and just ask for a generic and get it, then there is no problem. But the problem comes when we have inculcated a psychology in the patient that this is the drug, and unfortunately, illegally, some of our consultants and our doctors also have a stamp on the prescription say do not substitute. Some of you may have seen it. It is totally illegal. Nobody can put a seal on the prescription and say do not substitute. You can't tell that. But that happens in practice. So finally, it boils down to the behavior of prescribers, how genuine these prescribers are when they are going to prescribe. And do they think about the patient when they prescribe? There is no clear-cut answer.
Thank you, sir. Thank you for that answer. I think the person who asked the question got his or her answer. There's one small question, sir. I think that is the last one. If only government sector is controlled by drug policy, what about the private sector import of drugs? So that are we achieving the maximum of progress?
That is a question that you have said. You have to ask yourself, what did Professor Bibile say? He said that you should first of all get only effective drugs into the country, which is what the regulatory authority does. You will not see ineffective drugs coming into the country because we have been able to stop that. The next question is, as Professor Manuj said, can we say, no, we do not want 60 brands of paracetamol. We want only 10 brands of paracetamol so that there will be enough and there will be competition. We cannot do that because the regulations do not prevent us. The regulations do not say stop at 10. As long as these things are available, then you may have to register. But a new thing has come in. which may help. If you have 12 brands, when the 13th brand comes along, you can ask the question, what is the advantage of your 13th paracetamol over the 12 paracetamols? If there is no advantage, then there is no point in registering it. The only advantage that you can get is they will come and say, okay, we can provide it much cheaper than the existing 12. That's fine. So that will help the market. But other than that, the regulation does not exist to say you can limit, but if you have a regulation, then the full implementation of the policy can come. That is the answer I can give at the moment.
Thank you very much, Krishantha sir. I think the person got so answer. That comes to the end of our discussion. I would like to thank Professor Krishantha, Professor Indika, and Professor Manuj for contributing the 2 hours of their time, because they all are, I know, busy professionals. So contributing the 2 hours of their time for this discussion, and also Mr. Ranil Bipine for joining with us from Canada. Thank you very much, sir. Thank you all for coming to this and sharing your knowledge with the students who will be the responsible healthcare professionals in this country. So if there are no other queries, we can wind up the session.
Okay, thank you for organizing this. It's a very timely event. Actually, today is the death anniversary of Professor Bibile, 43rd, as far as I think correct.
Yes, sir.
And unfortunately, this year SPC is not commemorating for the first time for at least for last 2 decades the death anniversary of Professor Bibile, unfortunately. So it was a timely event, and thank you so much for organizing this.
I also joined with Manuj in appreciating the work that you are doing as Sira, and then getting the enthusiasm and the participation of all the students. So it's very good work. And again, like Manuj mentioned, at a time that even SPC has forgotten the responsibility, that's what your effort has to be commended. Very well done.
Thank you very much again. It was memories from a long, long time ago. I was a professor of pharmacology when Sira started and began, and I can remember both Indika and Manuj arguing with the former Secretary of Health on this. So you can see that there has been an influence. I hope that after some time it has gone down, but now it has been reborn, and that Sira will continue from the beginning, well, from where it was left off, so that we in Sri Lanka, all of us who have benefited from a free healthcare system, and all of you now benefiting from a free education, a university education, will continue this tradition of the people of this country contributing to free healthcare and free education through their taxes and getting the benefits back by the people who benefit from it. Thank you.
Thank you very much. I would like to take this opportunity to thank the audience as well, because there are medical students from Faculty of Medicine, University of Colombo, and representing all the other medical faculties as well. Thank you, friends, for joining. And there are pharmacy students who have joined, and also there are non-medical related students also have joined with interest. Thank you friends all for joining. I think we can wind up the session now. Thank you all. Have a good night.